In the first place, my thanks to Professor Jacques Janssens and the organizing committee for having me here. I'm going to give this lecture in tribute of a very dear friend of mine who struggled with breast cancer and ovarian cancer for the past 9 years. She died at the age of 58, and she was buried this morning. Good. If we're talking about advances in breast cancer, in order to picture this, we have to go a little bit back. We're going to have a look at what is present status and also what the future is going to bring. The advances made in breast cancer, well, the driving forces are always the same. It is out of need. It's a burden of disease, increasing patients' demand, improving outcome, health economics. Also, technical advances are backing up the outcome of patients, early detection, diagnosis, and treatment advances, and then also the social media. It was 16 February 2013, tagged in history as the date that Angelina Jolie, at the age of 37, was diagnosed carrying a BRCA gene mutation, and she had underwent a bilateral prophylactic mastectomy and reconstruction. This news had enormous impact on breast cancer awareness and the appreciation that breast cancer could have an underlying genetic risk. Social media, as you know, are the most powerful tool to spread information of any sort, also medical information. And in that regard, the effects of social media on public perception depend on the quality of information, which in general is known to be poor. In an effort to promote the quality and reliability of health information posted on the internet, the Health on the Net information, Health on the Net Foundation developed a code of ethics for the certification of health-related websites. Their site has a search engine to discover certified websites with reliable information on a specific health topic, in this case, breast cancer. The SEER data on breast cancer survival reveal a steady increase on overall survival over the past 30 years, from 75% to over 90%. Several factors are implicated with improvement of survival. In the first place, a better understanding of the process of carcinogenesis, and as a result, more and more efficient therapeutic options. Breast cancer mortality is generally reduced with mammography screening, although estimates are not statistically significant at all ages, and the magnitudes of effect are small. A certain effect of screening is that advanced stage cancer is reduced by screening for women aged 50 and older. At the same time, organization of healthcare with volume-based improvement of efficacy and multidisciplinary approach is responsible for a major jump in quality of care. Breast cancer as an entity runs through history for more than 5,000 years with notable landmarks in its exploration. Modern senology takes off around 1900s, where breast cancer is considered a hormonal sensitive disease that needs to be removed by extensive surgery. William Halsted, the professor of surgery at the Johns Hopkins Hospital in Baltimore, United States, introduced several new surgical techniques, most notably radical mastectomy for breast cancer in 1882. The main achievement of Halsted's operation was a reduction in local recurrences compared with other procedures. However, it became clear that the operation didn't improve overall survival. Nevertheless, radical mastectomy became the standard of operation for breast cancer for over 70 years throughout most of the 20th century. His time companion, Thomas Beatson, reported the observation of regression of metastatic breast cancer by surgical oophorectomy, and therefore he can be considered as the father of anti-hormonal treatment of breast cancer. The discovery of X-rays by Röntgen in 1896 laid the foundation of mammography. It was a time of revolutionary discoveries, thinking of Max Planck with his quantum theory, Albert Einstein with his relativity theory, and Marie Curie with the discovery of radioactive properties of a material which he called radium. In 1913, Albert Salomon, a German surgeon at the Royal Surgical University Clinic in Berlin, conducted a mammographic study on 3,000 mastectomies. He found microcalcifications in X-ray images of tumor samples, and his mammographs provided substantial information about the pathological difference between cancerous and normal breast tissue. In spite of this observation, mammography did not become a common practice until early 1950. By 1930, radiotherapy was introduced as an alternative to radical mastectomy. And Geoffrey Keynes, he was a surgeon at St. Bart's Hospital in London, developed the idea of treating breast cancer by radium implants. In 1948, the first results on combined use of simple mastectomy followed by external radiation therapy were published. The period 1960 to 1980 was characterized by three topics: the use of mammography for early detection of breast cancer, the evidence brought forward to end radical mastectomy, and the rise of breast cancer advocacy groups. In 1962, Robert Egan, he was radiologist at the MD Anderson Cancer Center in Houston, used mammography to diagnose occult breast cancer. Bernard Fisher, in the middle, he was professor of surgery at the University of Pittsburgh and also chaired the NSABP in the early 70s. He challenged Halstead's theory and concluded in his practice, changing NSABP B04 and B06, that less extensive surgery of the breast in combination with radiation therapy was more effective than radical mastectomy. Fisher's research was described as launching the breast cancer community into the modern era, as his works ultimately ended the standard practice of performing radical mastectomy. The 1970s also witnessed the beginning of breast cancer awareness campaigns. Prominent breast cancer activists in the 70s were the First Lady of the United States, Betty Ford, and journalist Rose Kushner. In 1974, Rose Kushner was diagnosed with breast cancer. She immediately began gathering information on the disease and the treatment process. She was stunned that radical mastectomy was still common, and she strongly opposed the routine use of one-step procedure in which surgeons had the authority to decide on the spot to perform immediate radical breast removal on an anesthetized patient. She advocated for a two-step surgical procedure which starts with biopsy, followed by surgery a few days later, if necessary, and discussed with the patient. Kushner was vindicated in 1979 when the National Institute of Health, based on the evidence provided by Fisher's trials, concluded that radical mastectomy was no longer appropriate. Since the inception of breast conservative surgery as standard surgical care, we witnessed the continuous improvement of radiation techniques. Advances in radiation physics and computer technology during the last quarter of the 20th century have made it possible to precisely map and target tumors using techniques such as conformal 3D radiation therapy, intensity modulated radiation therapy, intraoperative radiation therapy, and the use of radiosensitizers to improve the sensitivity of tumors to radiation. Technological advances in the scientific world during the 80s to follow, along with a boost in research and development in the pharma industry, caused a revolution in breast cancer therapy. Many drugs were entered clinical practice. We always will remember tamoxifen in the years 70, 77. first in the metastatic, afterwards in the first line. Cytotoxic drugs, the introduction of taxanes in the mid-90s, and then Herceptin, first in metastatic setting, late 89, and then 8 years to follow the use of Herceptin in adjuvant setting. We also looked at BRCA tumor suppressor genes associated with the increased risk for breast cancer. They were identified, and surgery was taken to another level with the sentinel node technique. In this slide, we have arrived in the present time, in the 21st century. The omics era, as we refer to, evolved from the technological know-how gathered in the Human Genome Project. The international effort to sequence the 3 billion DNA letters in the human genome is considered to be one of the most ambitious scientific undertakings of all time. Today, as a result of genomics, more than 1,500 disease genes have been identified. This increasing knowledge of the genetic basis of disease has a lot of ethical, legal, and social consequences to deal with, but enabled us to better understand the biology of cancer, and in particular breast cancer. Gene expression profiling is a technology for identifying these genes or their products, be it messenger RNA, proteins, or even metabolites, whose activity may be helpful in understanding the biological pathways in carcinogenesis, in drug discovery, guiding therapy, and assessing prognosis. We will later see in this discussion that a rapid evolution in molecular diagnostics from specific target gene profiling towards genome-wide profiling technologies opened the way to personalized cancer therapy, also called genomic-based oncology or precision oncology. The molecular classification of breast cancer based on gene profiling, expression profiles, is one of the first steps towards personalized cancer therapy. Gene expression profiling of human breast tumors revealed molecular subtypes with distinct gene signatures and associated clinical outcomes. Peru in 2000 came up with 4 main molecular subtypes, being luminal A, B, HER2 positive, and basal-like tumors. Clinical correlates of these molecular subtypes are based on hormone receptor status, HER2 receptor status, grade of tumor differentiation, and mitotic activity according to Key 67. At present, we have 2 validated gene expression profiles, which are commercially available, that guide therapy regarding the need for adjuvant chemotherapy in early-stage hormone receptor-positive breast cancer. Oncotype DX, predominantly used in the United States of America, and MammaPrint, which is superior to Oncotype DX, mainly used in Europe. State-of-the-art management regarding systemic therapy in early breast cancer is guided by this molecular classification and supported by the MammaPrint in the luminal A and Bs with intermediate risk factors based on age, tumor size, grade of differentiation, lymphovascular invasion, and positive lymph nodes. We have not only seen the evolution in molecular cancer diagnostic, but in recent years also many drugs and treatment strategies were developed. And this is a summary, which you all know. New drugs appeared in anti-hormonal category. Lots of oncogenic targets, mTOR, HER2, PARP, CD4, CD6 inhibitors, PI3K inhibitors, then cytotoxic drugs also, and then also new strategies, combination therapy, doubles, triplets, and also the extended use of tamoxifen at this point in time. The understanding of breast cancer has translated clinically in the identification of markers of tumor behavior, the so-called biomarkers. A cancer biomarker refers to a substance or a process that is indicative of the presence of cancer in the body. It may be a molecule secreted by a tumor or a specific response of the body to the presence of a cancer. Biomarkers can be used in cancer research in the clinic, theoretically in the following ways: risk evaluation, evaluation of tumor burden, identification of treatment strategies, targets to follow, evaluation of treatment response, recognizing the origin of treatment resistance, detection of residual disease after treatment, and understanding implications of tumor heterogeneity and clonal evolution. This slide summarizes the present clinical availability of biomarkers regarding diagnosis, prognosis, and therapy response. And we need to conclude that at this point in time, we haven't come a far end yet. In the near future, more and more cancer biomarkers will be recognized as molecular diagnostics move on from tissue-based target genomics to genome-wide profiling using next-generation sequencing based on liquid biopsy material. Technology has enabled us to isolate circulating tumor cells from peripheral blood, the so-called liquid biopsy. Tumor cells can be separated from blood cells on the basis of differences in physical and/or cell surface antigen properties. After isolation of circulating tumor cells and enrichment, these tumor cells can be identified by high-resolution imaging or even further step analysis by genomics, transcriptomics, or proteomic characterization of isolated cells. Let us focus for a moment on the potential advantages of liquid biopsy material analysis, be it at cellular, DNA, RNA, protein, or metabolic level relative to tissue biopsy material, where these very same components can be determined. The main advantage of liquid biopsy are being minimally invasive, so they can be measured serially and potentially follow changes in tumor behavior during treatment. Because blood is a systemic product, liquid biopsies may represent interior tumor heterogeneity. Tumor heterogeneity refers to the clonal evolution of the tumor as it advances, with cell clones gaining or some losing certain characteristics, thereby changing their biological behavior. The main disadvantage is that blood does not contain any information on spatial resolution of the tumor microenvironment, and an important aspect of tumor behavior. Spatial resolution of tumor microenvironment refers to the way the tumor and the surrounding cells, mainly blood cells, immune cells, and fibroblasts, interact. The tumor and the surrounding microenvironment are closely related and interact continuously. Tumors can influence the microenvironment by releasing extracellular signals, promoting tumor angiogenesis and inducing peripheral immune tolerance, while the immune cells in the microenvironment can affect the growth and evolution of cancer cells. This interaction can be evaluated only in tissue material, not in liquid biopsy material. Genomic analysis to date in practice involves fully automated PCR-based molecular diagnostic systems with interchangeable tumor panels, depending on the information that is needed on a specific tumor. They test one or multiple pre-specified exons of the genome of a tumor specimen and provide physicians fast access information on the tumor to guide specific targeted therapy. In the meantime, molecular diagnostics technology has progressed rapidly. At the moment, one is able to analyze in a very limited period of time substantial parts of the genome to identify changes in nucleotides sequencing that are responsible for overexpression of known but also of unknown enzymes involved in carcinogenesis. This technology, called next-generation sequencing, will provide us with new information that, linked to the clinical context, will give us new insight in carcinogenesis and will identify new biomarkers. In that respect, next-generation sequencing could be regarded as the unexplored library of carcinogenesis. Talking about next-generation sequences, we have entered the future of cancer research and treatment, and it's clear that new developments will follow in great pace. In analogy to precision medical oncology, new surgical techniques developed towards precision surgical oncology and will enter the clinical setting soon. Intraoperative imaging techniques making small breast tumors visible to the naked eye will enable surgeons to excise these tumors more precisely with minimal damage to the surrounding normal breast tissue. Tumors will be made visible by a tracer that binds to the tumor and shows to an infra or near-infrared fluorescence camera. There are two kinds of fluorophore. One, on the one hand, the target fluorophore that binds to the target, let's say for instance HER2. On the other hand, we have the non-targeted activatable fluorophores, being agents that emit fluorescence once activated by the enzymes present in the tumor, such as tumor proteases. Another interesting and elegant apparatus in research is the iKnife. It's an advanced electrosurgical technology whereby the vaporized smoke that is produced by the electrosurgery is analyzed simultaneously by a mass spectrometer to detect the chemicals in the biological sample. This allows real-time identification of the margins of malignant tissue in the breast. Other challenges facing us include the refining of gene profiling expression profiles to guide precision oncology. In the first place, I would say, to eradicate the term triple-negative breast cancer, where up to date no specific target is found. Information for next-generation sequencing technology on fluid biopsies during therapy will enable us to overcome drug resistance. Much hope is set on new strategies such as immunotherapy and by extrapolation vaccination technology, where the immune system is triggered to attack cancer cells from within. This talk on the advances in breast cancer care can be summarized by the Cancer Moonshot for the Future of Cancer Care speech of President Obama during his State of the Union address in 2016. He clearly identified the topics one should invest in to combat cancer more efficiently. A few of these items were already alluded to. We talked about fluid biopsy, precision surgery, genetic basis of disease and effects of triggers, internal or external, new generation targeted therapies, immune therapy and vaccination, and also the progress we made in molecular diagnostics. Molecular diagnosis, and these will be available commercially to sequence the DNA of a patient's tumor, and it will become the standard to assign cancer treatment regimens. A few other things which will be of interest in the future. In the first place, the artificial intelligence-based therapy designs. Even if we can extract tumor cells from blood and sequence their DNA as fast as possible, making a decision about which treatment to choose next is still a struggle. No oncologist can see through the thousands of clinical trials by keeping all of the patient's mutations in mind. Artificial intelligence algorithms can, and IBM developed a supercomputer, Watson, I don't know what happened to Crick, but it's called Watson, to find the most personalized treatment by sifting through all available evidence within minutes. Multifunctional radiology. It is a system of image-guided delivery of drugs of any kind to the tumor site in order to decrease systemic side effects and increase treatment effectiveness. A very logical step forward. Also interesting, the in silico trials. In silico trial investment, in silico testing, it's a new testing environment. It's also called organs on chip technique, where the whole cell environment and all the cell behaviors are simulated on a computer. And this to test the efficacy of candidate cancer drugs on billions of virtual human biological pathways stored in that computer. In that way, the huge financial risk for drug companies to invest in a failed drug candidate falls, and at the same time, efficient drugs will be discovered speedier. This is necessary as we obtain a better understanding of carcinogens and need more targets to be targeted. DNA cages. DNA cages. The most cancer treatments today destroy not only cancerous cells, but also healthy ones. The ultimate goal of delivering drugs only to cells that need to be treated using DNA cages holding a payload of drugs might be the answer. The cancer cell triggers or can trigger the DNA cage to open, and thus the drug could be only make an impact on those cells, but not the healthy cells who cannot open these DNA cages. This method could be used in clinical trials soon. As you see, there's a lot to come. Well, we have come a long way, and it will become exciting times for those involved in breast cancer care. And I will conclude with a statement of Nelson Mandela: after climbing a great hill, one only finds that there are many hills to climb. Success to climbers.